Good afternoon, everyone. It gives me great pleasure to be with you this afternoon in a very interesting session, and we look forward to very rich discussion on these important topics discussed today. My name is Dalala Romehi. I'm a consultant endocrinologist at King Hamad University Hospital, and I welcome you and our attendees virtually to this session. If you do have questions from our virtual attendees, please don't hesitate to put them in the Q&A. We'll be happy to ask our speakers at the end of the session. Without further ado, I start with the first speaker, Dr. Hussein Raef. He's a consultant endocrinologist at the Department of Medicine, King Faisal Specialist Hospital and Research Center in Riyadh, KSA. And he'll be speaking to us today about osteoporosis management in 2022. Welcome to the podium.
Assalamu alaikum. Thank you very much, Dr. Dalal. Thank you for the invitation. I'll be very happy to be here among colleagues, virtually and face-to-face as well. So I was asked to update you on especially the management, but also some issues in the diagnosis of osteoporosis that is currently issues that have been updated. Of course, this is a little bit of a wide topic, so I tried to choose, and I tried to have quick answers for those questions. How is fracture risk assessed? What is an appropriate evaluation for osteoporosis? Who needs pharmacological therapy? How is treatment monitored? And what is successful or failure of therapy in osteoporosis? What kind of medications we have and which one we should use? How long should the patient be treated? And I think because we're going in the spirit of 2022, osteoanabolic and dual therapy or dual action drugs are coming to us strongly, and I think there will be, if not already, some change in the paradigm of treatment of osteoporosis that we feel already in our practice. So in that regard, I will talk very briefly on sequential and combination therapy. So I try to depend on recent guidelines as well, which is the Endocrine Society and the European Society for Bone Disease. This is the definition of postmenopausal osteoporosis as outlined by the ACE. Of course, we all know about T-score less than minus 2.5 in any of the sites by BMD, but low trauma fracture, even regardless of the BMD, in a postmenopausal woman or in an elderly man is enough to diagnose osteoporosis. What about, this is if it's a spine or vertebral or hip fracture, but if it's any other site of fracture, then we have to have osteopenia as well to make the diagnosis. So a fracture in the humerus or in the foot and the ankle is not enough unless you have osteopenia. There's always exception, and we see, of course, osteoporotic fracture even in a normal BMD at time. So there's another definition based on the FRAX or the fracture assessment tool, which is osteopenia with high FRAX probability. Now, when it comes to the strength of the bone, we measure bone mass, but we know that the bone quality is something beyond bone mass at time. And both of them are important for the strength or the resistance of the bone. Therefore, fracture happens when this bone resistance decrease, whether it's due to decrease of quality or due to decrease in bone mass. So we know now that the quality of the bone present, of course, the amount of mineral, what we measure basically in bone density, but also collagen, also the way these trabeculi is being architect within the bone, or even the porosity of the cortical bone. All these features, unfortunately, we cannot measure easily. So just to give you a little bit of idea about the effect of risk factors in the fracture risk, Here is different curves or assessment of fracture risk, as you see here on this axis, the y-axis, and the T-score as in the x-axis. But this is different, depends on family history, like in this curve, the use of glucocorticoid in this curve, or prior history of fracture. And you see for each of these risk factors, whether women and men, that the risk of fracture increase tremendously. And it's even with the same T-score, let's say -2, can be different when there is a risk factor or no risk factor. So risk factor will shift the risk, increase the risk or decrease the risk accordingly, even independent of the T-score, which we depend on mostly. Therefore, we have to have different tools to assess the risk of fracture and to make a decision. Now, I'm giving you here some examples where bone density does not really reflect the real quality of the bone. Diabetes is one of this example. Steroid-induced osteoporosis is a very good example, as well as rheumatoid arthritis. So how do we account for this? Do we have the tool? We have actually some tools. We have the MRI, we have the QCT, we have certain research type of tools that we don't use in real life, but we use in research to identify the quality of the bone, the trabecular structure, et cetera, et cetera. But fortunately, recently, we have something called Trabecular Bone Score, TBS. This is basically a software program that you can add for your bone densitometry. And what it does is very simple. It just measures the porosity of the bone, trabecular bone, like in these two examples. Those might have similar bone density, but certainly they have different porosity, as you can see very clearly. So the software can differentiate those two. Of course, we have to prove that this is clinically beneficial. And indeed, there are studies that show this. This is a Japanese study published in GBMR showing that the TBS tertile versus the BMD levels, both were independently able to predict fracture risk. So if you have a low TBS score, or meaning maybe high TBS score, meaning a lot of porosity, and low BMD, then the risk of fracture becomes much higher. And this is why TBS now is incorporated in the FRAX tool if you have that available for you. So another tool to determine risk is the FRAX. We're all familiar with the FRAX, the fracture assessment, which gives you the risk for fracture based on risk factors, plus minus BMD, for the next 10 years. Now, this depends on certain risk factors that is easy to measure. They're not the only risk factors for osteoporosis or fracture, but they're the easiest to measure, which is the age, the sex of the patient, the weight, the height, previous history of fracture, which is very strong, actually, predictive, familial history of hip fracture, smoking, glucocorticoid, or secondary causes like diabetes, rheumatoid arthritis specifically, previous or current alcohol ingestion. And if you have the BMD, you can also imply it here. But you can use the FRAX even without BMD. You don't have to have the BMD to use the FRAX and assess the fracture rate. And also you can implement TBS. So if you have the TBS score, then you can also implement it in your FRAX. Now we have to know the limitation. FRAX is not really a perfect tool. It does not account for number of fractures, and we know the number of fractures is very much predictive of further fractures. It does not account for the dose or duration of glucocorticoid. It doesn't have a dose dependent in terms of alcohol or smoking. Also, it does not account for falling, which is a major reason why people fracture. So some of the countries have adjusted their tool, similar to FRAX, to incorporate those factors, and I think this is a good idea, of course, to do so. Now, just to quiz you here, since this is supposed to be Meet the Professor session, more interactive, I'm giving you 3 cases. One's a 62-year-old, healthy, with a very low T-score of minus 3.3 on DEXA, BMI 19, so this is another risk factor. A 79-year-old woman, again healthy, with BMI of 22 and a T-score of minus 2.2 in the spine. And another case of 83-year-old with a family history of hip fracture, BMI 24 and T-score in the spine that is appears to be within normal range for that patient. So which one actually has more risk of fracture? Anybody would like to guess? All right, I'll show you. I mean, naturally, we think the BMD is the predictive factor, but actually age is very strong. So indeed, this patient with 83 has higher risk for fracture than the 62-year-old who has even much lower BMD. And the reason is the risk factor is the age. So age has a lot of toll on the quality of the bone. And this is why we have more risk for fracture in those patients, but also other risk factors. In this particular patient, the parental history of hip fracture. So what is the main message of a lot of guidelines these days? The main message is target high risk. Target high risk. Put your money where it should be. Don't waste your efforts in diagnosis and management when there is no benefit, when there is no much benefit. And I think this is the highlight of almost every guideline I looked at. So this is one from the European Society. And actually, this one is very practical because it assesses, of course, you need to assess the risk for osteoporosis in every postmenopausal woman and in every man above age 50. I mean, above age 50, everybody should be assessed. And this can be done by using risk factors or FRAX without BMD, of course. If you have a low risk based on this, you don't need to do anything. You don't even need to do BMD. Maybe at certain age, at 65 or so, you can do that later on. If you have a high risk, you can treat those patients, even without BMD sometimes, if you don't have the BMD, but better, of course, to have BMD. It is the intermediate risk. It is those people who have some risk factors, but not really clear, or they have sustained maybe a fracture that you need to do some further workup, which is BMD, and then assess them whether they are lower or high risk for fracture and decide about treatment. So this is kind of easy clinical way. Of course, there are other ways of doing things in the clinic. So in this particular guideline, women aged over 65 with a prior fragility fracture or history of fragility fracture should be treated regardless. You know, they have proven to you they're osteoporotic by a fracture and by age of 65 and above. However, anybody below that, or anybody who doesn't have fracture, then their intervention to treat or not to treat, to do BMD or not to do BMD, is based on a different parameters. And they have these graphs, which I think they're very useful, especially if the resources for BMD and so forth is a little bit scarce. Actually here, if DEXA or BMD is available, they tell you with these graphs, and this is what the European use now, based on age and FRAX probability. So basically, if your patient comes here in the green, you don't need to treat, you don't need to do any BMD. If the BMD is available and your patient FRAX comes here, depends on his age and FRAX probability, then it's better to measure BMD, and either they will be in the middle or in the high level, and you can decide about treatment. Now, if you don't have BMD so available, then those patients who runs in this part can be treated even without BMD. It is those patients in the middle or intermediate risk that you need to do BMD, and then you make a decision to treat them or not, because their FRAX will change after the BMD, and they might go in the higher risk group. So this is very practical way. You know, you can use those scores. Of course, those scores are based on European, not on our population, but you know, it's something to try to duplicate. If we go by the North American parameters or guidelines, this is the ACE guideline, and tell you that if you have a patient with a T-score of -1 to -2.5, which means an osteopenia, with a FRAX probability that is high. For the US, it is more than 20% for major osteoporotic fracture, more than 2.5 or 3% for hip fracture, then those patients should be definitely treated. Of course, somebody who has already a fracture should be treated for sure, but we're talking about those with high risk but has no fractures before. They also define a group, which I'm interested in to later talk about the issue of the anabolics, which is the very high-risk group. And what is this? How do they define those patients? Those are the ones who had recent fracture, and we know fracture is a very strong risk factor to another fracture. So those who had recent fracture, and you can say maybe more than one fracture, you might define it this way, but certainly a fracture will be a very something that put the patient in high risk. Fracture while on therapy, multiple fractures. Fractures when somebody on steroids is even more significant. Those who have extremely low T-score, like -3 or worse, or have high risk of falling, therefore they are much prone for fracture, or they have very high probability by FRAX, they define it as more than 30%, but we can define it according to each country's specifics. Those patients, the very high-risk group, they have a little different algorithm of treatment, and I think this is a new paradigm, which I will review with you after a few slides. Now, just quickly, once you have established osteoporosis, you need to do a quick evaluation, not much. If the osteoporosis is pretty much expected in this patient, all what you need to do is basic lab, CBC, bone profile, vitamin D level, thyroid function test. In male, testosterone should be measured because hypogonadism is quite often a secondary factor in male osteoporosis. Now, I want to talk about two things, which is measuring 24-hour urine calcium and assessment of the spine, which I think is very important in some patients. Why 24-hour urine calcium? Because it can tell you a little bit about two issues, whether this patient is losing so much calcium in the urine, and this is a situation we call idiopathic hypercalciuria, but also tells you if the urine calcium is so low that this patient either does not take much calcium at all, so he's calcium deficient, or even have malabsorption. So you can really use it both ways. Why vertebral fracture? Because why assessment of spine? Because a silent vertebral fracture is common. Actually, we looked in this, and a good number, maybe 20% of patients above certain age of 50 or 60 might have a silent vertebral fracture. How do we do this? Either by simple lateral spine X-ray, or if you have the DEXA doing the vertebral morphometry, then you ask them to do that. Now, the indication to do it, I think it's in everybody who's going to be treated for osteoporosis, but they specifically mention postmenopausal women who have a history of height loss, kyphosis, or use of steroid, because steroid is a very strong factor for vertebral fracture, or those who have clear osteoporosis with BMD less than -2.5, and anybody who have sustained another non-vertebral fracture should be looked for any silent vertebral fracture. And we know that vertebral fracture here is predictive of further fracturing in those patients. So up to 30% in postmenopausal women and 50 to 80% of men might have some factors to account for osteoporosis and what we call secondary osteoporosis. Of course, there's a long list of those factors that you all know of. Now, let's touch on current treatments before we go to the algorithm. This is the most current table of treatment available, and it's just by alphabetical orders. We have the abaloparatide, the anabolic, the alendronate, calcitonin still there, rarely we use, of course, denosumab, ibandronate, raloxifene, which sometimes we use, not common, risedronate, romosozumab, which is another anabolic, and zoledronic acid and teriparatide. Now, here is all of them have evidence for vertebral fracture prevention or decrease in vertebral fracture. But look, when your aim is non-vertebral or hip, the evidence becomes less. So treatment like with ibandronate or raloxifene or calcitonin will not have evidence for non-vertebral and hip fracture. Even teriparatide, actually, in the major study, did not show hip, although it showed non-vertebral, although some post-analysis showed improvement in the architect of the hip as well. So this is actually the ACE guideline, and I liked it because it kind of incorporates the duration and the follow-up on those patients in one algorithm. And I'll go a little bit with you. So initially, of course, evaluating the secondary causes and focusing on non-pharmacological issues like lifestyle, weight-bearing, calcium and vitamin D supplementation. Now, they're dividing the group of patients in high risk and very high risk. So only high risk and very high risk will get treatment, basically. The low risk should not get treatment. And again, they define high risk as anybody who meet the criteria without fracture, and the very high risk who meet the criteria plus fracture. However, we might differ here because many of us will consider the first fracture still as high risk and not necessarily very high risk, but this is really individual judgment. Now, for the high risk, or let's say moderate to high risk patients, usually bisphosphonate is the way to go, and this is oral bisphosphonate or IV bisphosphonate. If, for convenience or for whatever reason, some people prefer IV source. The ACE guideline put denosumab as first line, but I can tell you other guidelines, like the European, would put it as alternative therapy, so meaning a second-line therapy. So if any of those didn't work or not suitable, we can still use ibandronate and raloxifene, knowing that it will not work on the hip or does not have evidence for the hip, to be more specific, or use denosumab as a strong, of course, very strong anti-resorptive therapy. They recommend assessment every year, but many guidelines would say every 1 to 2 years, actually. And if you have a successful therapy, meaning increasing in BMD or even stability in BMD with no further fracture, then you can continue this treatment for up to 3 to 5 years. If you use IV zoledronic acid, then it's 3 years usually, but you can go a little higher. If it's an oral therapy, then it's usually 5 years. And after that, you consider a holiday from bisphosphonate. And during this holiday, you should monitor your patient, of course, by BMD every couple of years and also clinically. And if they sustain a fracture or if they showed a significant loss of BMD, and this is significant, should be significant, then you might consider to go back to treatment. On the other hand, if they did not respond to your therapy by progression or by fracture, then you need to assess a number of things, including compliance, including calcium, vitamin D sources, because this is a common cause for failure of therapy, and then consider possibly switching to stronger anti-resorptive or consider anabolic therapy at that point. Now, for the very high-risk patient, and we can agree that at least those patients have one fracture, but maybe more than one fracture, or they're very frail patient from beginning, they have very low score, they're using also steroids, you might actually start to think in a different paradigm. And I think this is where we're shifting our thinking to use anabolic first. So the guidelines say consider abaloparatide, romosozumab or teriparatide, all of them are anabolics, but also they mentioned denosumab as zoledronic because they are the most effective and the strongest anti-resorptive therapy we have. So you go for the strongest therapy, basically. And those patients need maybe assessment on a yearly basis initially. And it depends what you choose, then your follow-up is going to be different. So if you choose to use bisphosphonate as example, here you can go to 5 to 6 years of therapy instead of 3 years, and then give a holiday if the patient is stable. If you go by any of the anabolic like abalo, tira, or romosozumab, certainly you need to follow this with anti-resorptive therapy. So romosozumab goes for 1 year, the abalo and teriparatide go for 2 years, and then you have to follow with anti-resorptive therapy, otherwise you're going to lose the effect. Denosumab is a special case. So here, either you have to continue therapy for a long time, maybe indefinitely. So you have to choose your patient from beginning that they will be compliant, they will be deserving such treatment for long term. But if you think of, if you got very good result and you think you need to stop, then you have to follow with very strong anti-resorptive therapy. Otherwise, something, rebound effect can happen. And here I want to show you this because we learned this from the denosumab trial that, as you know, went for almost 10 years. And then when they stopped the denosumab, whether the patient started from beginning or started from placebo and then denosumab, there was this quick decrease in their BMD, whether in the spine or the hip. Even the hip was even more, actually, went even to below the baseline. What does that mean? It meant multiple fractures, especially multiple vertebral fractures, especially in the high-risk group that already had fracture to start with. So that was kind of an alarm, and this is why bisphosphonate, specifically maybe IV zoledronic, should be following denosumab therapy if you choose this therapy for your patient, unless you think they need it forever. Now, just a word about osteoanabolic and dual action therapies. Now, I think this is a little shift in our way we treat to more anabolic. We have two anabolic that depend on PTH receptor, which is the PTH analog, teriparatide, or the PTH-related peptide analog, the abaloparatide. They're very, very similar in terms because they work on the same receptors, although there's slight difference because abaloparatide seems to favor the anabolic effect, the transient anabolic effect, little more than teriparatide. So it might have a little bit more anabolic window than teriparatide. The romosozumab, by working in a different way on the what we call Wnt pathway instead of the PTH-IGF-1 receptor pathway, seems to stimulate bone formation, but also to inhibit bone resorption at the same time. The window is like a 1 year only. So this is just to explain that bone formation depends on osteoblast, and this can be stimulated through the stem cells by the Wnt pathway or through the direct effect on the osteoblast with the IGF-1, PTH-IGF-1 receptor pathway. Now, for the Wnt pathway, it's a complex receptor. The Wnt with the low-density lipoprotein receptor 5-6 will stimulate, but then there is a protein called sclerostin that inhibit this pathway, meaning decrease bone formation. So if we inhibit this sclerostin by creating antibody to it, which is the romosozumab basically, then we can stop the sclerostin from working and we favor the bone formation again. And this is what happened with the romosozumab. It seems to work on the modeling. There's something called remodeling and modeling, and PTH and also recombinant PTH or recombinant PTH-related peptide work mostly on the remodeling, favoring modeling little, where the Wnt pathway work on modeling, and this is why its effect on the cortical bone is better. So I will go quickly that the romosozumab, since it's the new drug, has shown increased bone density. and decrease vertebral fracture in the frame study. And the frame study did not show decrease in non-vertebral, but then the ARC study, which was romosozumab versus alendronate, showed decrease in vertebral as well as non-vertebral and hip fractures, showed some increase in cardiovascular risks, and this was a warning for this drug. Maybe I skipped the monitoring. This usually by DEXA every 1 to 2 years, and the successful therapy, as we already stated, stable or increase in BMD and no fracture. Non-responder are those who lose bone quickly, more than 4% per year while on therapy, or fracture beyond the 12 months of treatment with anti-resorptive. If the fracture happened early, then it's not necessarily a failure of therapy. When you have a failure, always consider those issues. In addition to compliance, that the patient maybe already have a low turnover in the bone, and your and your anti-resorptive may not be working very well. Just one word, if you give me 1 minute. The sequential therapy is something now naturally will happen whenever we have anti-resorptive therapy, like denosumab. Of course, we will follow with another therapy. When we have anabolic therapy like abaloparatide, teriparatide, romosozumab, it will happen with sequential therapy with an anti-resorptive therapy. The issue that I want to tell you that if you use denosumab, you don't want to follow it with anabolic. It's the opposite. So yes, bisphosphonate can be followed sometimes if you have a failure of therapy with anabolic, and you can still have an effect. But if you use denosumab, you have to be very careful not to follow with teriparatide, because you're going to get in the first year a decrease in bone, not increase. And this is shown in a small study called Data Trial, which I didn't have time to show you. So what to do in this case? Either you have to combine, which is usually we don't recommend in general, but in this particular situation, if you have a failure on denosumab, where somebody has been on denosumab for a long time, and you want to go to anabolic, not anti-resorptive, then you have to combine therapy. And this is maybe the only time you combine therapy with anabolic and denosumab. Thank you very much.